Most people are surprised to learn that children of all ages suffer from various forms of liver disease. While the spectrum of children's liver disease is similar to adults, it's not the same. We are very pleased today to welcome Dr. Richard Schreiber to speak on the topic liver disease and jaundice in newborns. Dr. Schreiber is the Senior Liver Specialist and Director of Pediatric Liver Transplant Program at the BC Children's Hospital. Dr. Schreiber's outstanding work helps to save the lives of many children who are born with rare, serious liver disease. Ultimately, he and his team strive towards the day when all pediatric liver diseases are cured. Please join me in welcoming Dr. Richard Schreiber and our host, Valeria Zaborska.
Welcome, Dr. Schreiber. It's an absolute pleasure to have you here with us. So for our first question, can you please tell us what is jaundice and is it common in newborns?
Well, first of all, let me thank Monica for that very, very kind introduction. I'm delighted to be here, and I really want to thank the CLF for giving opportunity to speak about liver disease in young children. Now, hi Val, and nice to meet you. Regarding your question about jaundice, jaundice actually is a condition where there is a yellow discoloration of the skin or the eyes. This happens because there's too much bilirubin in the blood, circulating in the blood. Bilirubin is a yellow pigment, and it comes from the breakdown of red blood cells. When the cells break down, the hemoglobin in the cells also get broken down. This is called heme. In fact, that's the substance that carries oxygen in your blood. When red cells break down, and they do so every 120 days, your bodies are making new cells all the time, the red cells get broken down, the heme gets broken down, and bilirubin gets produced. This yellow pigment bilirubin is then brought to the liver. And in the liver, the bilirubin gets eliminated through the excretion of bilirubin into the intestines. Before that happens, though, the liver changes the bilirubin into a conjugated form of bilirubin, and then that gets excreted into your intestines. It's because of the excretion of bilirubin, the breakdown product of red cells, that actually your stools are colored brown, because bilirubin is a pigmented product.
And so how common is it in newborns as opposed to older adults?
So having jaundice in newborns, there being yellowing of the skin or the eyes, is very common in newborn children. In fact, it is estimated that 2/3 to 3/4 of healthy babies will have transient jaundice in the first few days of life. Now, why does that happen? It happens because newborns have immaturity of the machinery that break down that bilirubin, that help excrete it from the liver. The machinery, or the enzyme that conjugates bilirubin at birth, doesn't work at 100%. It's only working at 50%. And because of that, when the red cells in the healthy newborn are breaking down, the bilirubin can't be conjugated as quickly, and it hence builds up. And it takes a few days, even up to a week, for that enzyme to come up to full activity, to 100% activity, to conjugate all that bilirubin so it can get eliminated by the liver. And because of that delay in enzyme activity, babies tend to have higher bilirubin levels, and therefore many, many healthy babies have jaundice. But we call this physiologic or normal jaundice of the baby.
Thank you. So when a baby has high levels of bilirubin and it's not physiologic, why is this a concern? What kind of repercussions can it have for the baby?
Well, when babies end up with very, very high bilirubin levels, excess levels, 10 times normal levels, they're at risk to develop deposition, or to have deposition of the bilirubin in various tissues. And one of the most serious places where bilirubin, if it's really, really high, is in the brain. It can get deposited in the brain and lead to an encephalopathy or brain changes, even to the extent that you have a severe condition called kernicterus, which is a brain injury from excess bilirubin. Thankfully, however, this is very rare. Most newborns who have jaundice end up clearing their jaundice within the first week of life. The enzymes get going and the bilirubin ends up clearing. Risk factors for babies to have very high levels of bilirubin are those who have prematurity, they're born before 37 weeks, or in those babies who have too much breakdown of their red cells. For example, if they had bleeding during their delivery, or if they have excessive bruising where most of the red cells are breaking down too fast, the bilirubin builds up too quickly, and that could lead to problems.
And how do doctors investigate or measure the amount of bilirubin in a baby?
So the standard way to do this is if you have a baby who appears very yellow, one would then proceed with testing the bilirubin by measuring it in the blood. This is basically a blood test that's done to measure what we call serum bilirubin. And in fact, there are two types of bilirubin. There's the bilirubin that's circulating before it gets to the liver, or what we call unconjugated bilirubin, and there's bilirubin that can circulate after it's being conjugated, or what we call conjugated bilirubin. And it's the totality of unconjugated and conjugated bilirubin that make up the total bilirubin. And these are different measurements that your doctor may order when they're trying to assess how high the bilirubin is in a baby who's appearing yellow. And of course, there's treatment for that. Most babies who have some elevation in their bilirubin, if it's not too high, one just has to monitor. Babies where the levels go up higher, we have the opportunity to do what we call phototherapy. Because bilirubin is a pigmented substance, the light can actually help break it down. And so you may see some babies in the newborn period that undergo a few days of phototherapy to help manage the bilirubin.
And then, so you mentioned that sometimes parents or doctors can see this jaundice in a baby because they turn yellow. Are there any other signs or symptoms to watch for, maybe after leaving home from the hospital?
Yes, so when you go home from hospital, you should continue to observe for the intensity of the yellow. And the other thing is to make sure that your baby is well hydrated. In other words, that you continue to feed them well and that they're peeing well, that they're receiving adequate nutrition. All that helps to make those enzymes mature, so the conjugating enzymes rev up, and also keeps the baby well hydrated, so the bilirubin is excreted better. I should mention that there are some babies who have prolonged but not very high jaundice, and that's mainly seen in breastfed babies. As it turns out, breastfed babies could have an attenuation in the revving up of that enzyme, and so they can have persistence of yellowness, persistence of their jaundice that can last for more than 2 or 3 weeks. That doesn't mean that your baby's in trouble. Your doctor will be monitoring that with you, and of course, as long as the levels aren't getting very high, it becomes of no concern. This is called benign or non-concerning breast milk jaundice. So at the end of the day, most newborns are jaundiced, 2/3 to 3/4, but most of them have physiologic or what we call benign jaundice. The vast majority of babies do not have a problem because they're yellow.
Okay, great, thank you so much. So shifting a little bit away from bilirubin, can babies be born with other types of liver disease? Is there a genetic component? And what are some of the common causes of other types of liver diseases?
So that's an excellent question. The reality is that liver disease occurs rarely in newborns. About 1 in every 2,500 newborns will have a liver disease. That's compared to 75% of all newborns having jaundice. So not every baby who has jaundice has a liver disease. In fact, as I mentioned, most babies have healthy, benign jaundice. This is called an unconjugated hyperbilirubinemia. It's babies who have a high conjugated fraction of bilirubin. That is a sign for liver disease. Unfortunately, all you have to do is looking at the baby to assess whether they're yellow. And so finding the rare liver disease in a yellow baby is like finding a yellow needle in a yellow haystack. Vast majorities of babies have benign jaundice, but there may be a rare baby with jaundice who has a liver disease. And it's extraordinarily difficult to sort those two things out. So what doctors tend to do and what we recommend is if a baby has prolonged jaundice, more than 2 weeks of jaundice in life, more than 2 weeks of life, or I'm going to let that out. We can take this over. So if a child is persistently jaundiced for more than 2 weeks, the recommendation is for that child to end up with a bilirubin test to assess for what type of bilirubin they have. If it's an unconjugated bilirubin, no problem. If it's conjugated, a red flag goes up that there could be an underlying liver disease. But there are other features to look at in a baby who is jaundiced to help decide if they have a liver disease. And one of the cardinal features to look at is the color of the stool. If your baby's poop is pale, white, not colored, what we call acholic, and is jaundiced, those two things together raise a flag that there may be an underlying liver disease. Here in British Columbia, we are uniquely having this stool color card program where every single mother who delivers a baby, before they get discharged from maternity, are issued one of these stool color cards. They are asked to monitor their kid's poop color for the first 30 days of life. And if they notice that there's an abnormal stool color, that's numbers 1 through number 6, and that could be pale white or even pale green, they are asked to contact perinatal services through a phone number or an email, and we will then respond to follow that up, or they can go to their doctor with the card and have their doctor assess their baby.
So if, for example, I were to give birth and my baby's stool is pale, what does that mean? What disease does it usually indicate?
So it could indicate a variety of possible liver diseases. And there are various liver diseases in the newborn. They can range from being a genetic, inherited, or a familial liver disease. They can be because of an infection. It could be because of some kind of structural change in the biliary system that helps to excrete the bilirubin. It could be an endocrine problem. And in fact, about 20% of babies with a liver issue, we don't actually ever find out the reason for it. So there are a variety of causes of liver disease in the newborn period. But Valerie, these are very different than the causes of liver diseases in adults. For example, I mentioned to you that babies may have an infection that causes liver disease. Well, many adults will know that hepatitis B or hepatitis C are leading causes of liver disease in adults. This does not happen in the newborn liver. The viral causes of liver disease in a newborn are because of enteroviruses, such as a herpes virus, or perhaps a Coxsackie virus, but it's not hepatitis B or hepatitis C. Also, I'd like to point out that we don't see conditions like gallstone disease in a newborn baby, which, as you know, happens often on the adult side. And it's important to also know that we don't see liver cancer in newborns. For example, hepatocellular carcinoma is not a cause of liver disease in the newborn period. So there are important differences between adult and newborn liver disease, and that's why it's important that you see your pediatric or family doctor and perhaps even get a referral to a specialist like I am at Children's Hospital to look at your baby from a pediatric liver perspective.
Thank you. So a common liver disease that I hear about in children is something called biliary atresia. Can you please explain what that is and what the signs and symptoms are and what it means for the baby?
So biliary atresia is a leading cause of liver disease in the newborn period. In fact, it accounts for upwards of 40 to 50% of all newborns who have a liver disease problem. The incidence of biliary atresia in British Columbia is about 1 in 15,000 live births. So it's still a rare disease, but it's important to recognize this condition because it is the leading cause of cirrhosis in children, and it's the #1 reason for why children need a liver transplant. So biliary atresia is the most important pediatric liver disease.
And given how small and fragile babies are, how do we treat biliary atresia or other liver diseases in children? And once they are treated, what is the success rate? Can they be cured, or are a lot of them something that you have to live with lifelong?
So biliary atresia, as I mentioned, is a rare liver disease. It's not an inherited condition. It's not run in families. In other words, these babies acquire this condition sometime in the perinatal, around the time of delivery. And what happens in this disease is there's a progressive obliteration, a blockage of the bile duct. This is like a tube, the draining tube from the liver to the intestine. That's the tube that drains the bilirubin. And for reasons that we don't understand yet, the bile duct becomes obliterated progressively in the first months of life. That leads to the presence of jaundice. That leads to the presence of pale stools because the bilirubin is not getting excreted from the liver because the tube is blocked. And if that continues, it is the most rapidly progressive liver disease. And if left untreated and it progresses, children will die by the age of 2 or 3 years of age. And so it's important to recognize the disease early and then to offer treatment. And the treatment for biliary atresia is sequential. The first step to treat is to recognize the disease and then offer surgery. In other words, one wants to remove that atretic blocked bile duct, and we put up a new conduit, a new loop of the bowel to the liver. We create that. It's called a Roux-en-Y, or a Kasai procedure, where we develop a new excretion tube for the liver, and that allows for the bilirubin to then get excreted back into the intestine. That Kasai procedure leads to the clearance of the bilirubin and the alleviation of liver congestion, which then prevents the progression, the rapid progression of the liver disease.
Okay. And if, for example, a procedure such as this doesn't work, can a baby have a liver transplant? And if yes, where does that take place in Canada? And what are some of the challenges with transplantation in the newborn age or the pediatric age in the country?
So let me step back a little bit for you before we get into transplant and talk a little bit about this Kasai procedure. We know that the Kasai procedure is most successful when it's performed early. The later that procedure is performed, the worse the baby outcome is. And by late, I mean if the biliary atresia is not recognized by 3 months of age, by 90 days of age, and the Kasai is performed after that age, the baby has only about a 10% chance of clearing the jaundice. In contrast, when the baby is recognized early, say by the first month of age, and the Kasai procedure is performed early, there is more than a 60 to 80% chance that the baby will have a successful outcome. So I'm trying to emphasize here that the key for management of biliary atresia, the first step getting to that Kasai procedure, is early referral and early detection of the disease so the management can be instituted in a timely manner. And so when a baby is jaundiced and has pale stools, it's crucial that that baby get referred for an assessment for biliary atresia. The baby will then have a number of laboratory studies, but ultimately will go to the operating room to have a Kasai procedure. So that's the first step, and it needs to be done early. Unfortunately, throughout the world, there's a problem of delayed referral for biliary atresia. So right from the get-go, kids need to be identified early. The reason why there's delay in the diagnosis and treatment is because these cases aren't recognized. As I mentioned, yellow babies are thought to be very healthy, and people don't think of them as having an underlying liver disease. In most cases, that will be true. The baby will be healthy. Being yellow, it will eventually clear without having an underlying liver disease. But for that rare 1 in 10,000 baby or 1 in 15,000 birth baby, one needs to consider biliary atresia. The second part of this is that most people don't even know to follow stool color after birth. It's very important to follow your infant stool color. In fact, most family doctors and healthcare professionals managing newborns don't look at stool color as part of their routine assessment. So it's important to look at the stool color, and that's why we have this unique program in British Columbia to help screen for this condition so that we can diagnose it early. And finally, and unfortunately, many babies don't have a blood test if they're yellow. If they remain jaundiced for more than 2 weeks of age, most of the time no tests are done and people are said to have, quote, breast milk benign jaundice. So the third thing is that the Canadian Pediatric Society and the American Academy of Pediatrics and other global world pediatric societies recommend that every single baby who has persistent jaundice for more than 2 weeks should have a blood test. And with that test, the pickup of liver disease will be early, and hence the referral will be instigated in a timely manner and treatment can happen. So if the Kasai procedure actually, Valerie, if it happens in the right time, let's say before 60 days of life, the chances are the baby will then go on to be pretty stable and healthy for many, many years. Unfortunately, if the procedure happens late and is not successful and the baby doesn't clear their jaundice, that's when you need to have a liver transplant. So that's the time that liver transplant will be offered for a baby who has a failed Kasai. And it also can happen in older children even if they had a successful Kasai, still have progression of their disease. But they're much older, they're bigger sized, and the transplant works out better. So liver transplant.
Yeah.
Liver transplant in babies and young children is a remarkable achievement for the health of kids and for survival in those with liver disease. And liver transplant in Canada was first performed in 1985. That's the first successful liver transplant. And that person, now aged 40, is still living today. And so liver transplants has had a remarkable impact in the management of liver disease in children. Their survival rates are pretty good. We're talking about upwards of 80% survival, and we mean long-term survival. In other words, if you undergo a liver transplant and really get through the first year, which is the difficult time, if you get through that first year, you then live forever as long as you take care of the graft. So the opportunity to do liver transplantation today is a very successful intervention for children who have what we call end-stage liver disease.
And this was a question from one of our audience members. Can a parent donate a part of their liver for the transplant, or does it have to be transplanted from someone else?
Well, that's a great question. And the liver, you know, I love the organ. It's a beautiful organ, and it's a very, very special and unique organ. The liver is the only organ in the body that can regenerate. You can take a piece of a liver from a 70-year-old adult and put that piece into a 3-month-old baby, and that liver will go on healthy, and it will grow into the size of the baby, and it'll survive for over 100 years. So the liver has great capacity. It's the only organ that can do that. And so that's why if you take care of a liver after transplant, that liver will go on and survive for many, many years. It's very different than other organ transplants, say a kidney or a heart. Well, eventually the organ deteriorates and you need to go for another one. That's not true in liver. So living-related donor liver transplant, that means using a piece from an adult, a live adult, and taking a piece of that liver and putting it into a baby is available and is currently used a lot in Canada for liver transplantation in children. In fact, Canada is one of the leaders for living-related liver transplants, and upwards of 60 to 70% of our transplants here in Canada are living-related liver transplants, and they do very, very well. Of course, it requires coordination. One needs to make sure that the adult donor, and that can be a parent, it could be a cousin, it could be another relative, it could be a friend of the family, or even an anonymous donor, needs to be evaluated properly to make sure they have eligibility to donate a part of their liver, but that does happen. I should mention in Canada, we only do about 40 liver transplants in children throughout the whole country. And so in order for each center to have enough experience, liver transplant is centralized in Canada. There are only 3 centers in Canada doing pediatric liver transplant today. That's a center in Montreal, a center in Toronto, and one in Edmonton. So that all transplants in Canada are done in a centralized manner so that these patients have very experienced centers doing their transplants.
Great, thank you. And hopefully one day in Vancouver we'll have a center as well.
Well, we're trying to get one going here in BC, and you know, hopefully that will occur. It would be terrific to have a localized pediatric transplant center for kids, for our BC children. So we're working on it.
Great. Actually, one last question, Dr. Schreiber. So this is from audience member as well, and very thematic given the current state of the world and the pandemic. My child with liver disease is under 16. He doesn't qualify for the COVID vaccine yet. What should I do if he gets COVID?
Well, that's an excellent and timely question. We're getting that question every day from families. So the first thing is that one needs to continue to practice proper public health care as recommended by our public health community. That means keeping distance, washing your hands, wearing a mask, all the standard recommendations. They apply to children as well. They need to be careful about COVID risk. That said, there is some data to come out to say that kids have much lower severity of disease with their COVID compared to adults. And that's because kids' immune systems are different and they have fewer comorbidities. Kids don't have chronic heart disease or high risk for high blood pressure or diabetes and the like. So kids have low risk for severe disease, hospitalization and ICU having their COVID. That said, I'm sure you've heard about the pediatric inflammatory multi-system syndrome, or so-called PIMS, where some kids get very sick with COVID. That actually occurs in only 2% of kids, and even though they get very sick and some of them need to be in the ICU, the rate of mortality or death is not very high. So they get sick, but they seem to overcome this disease. The last thing I want to say is that parents are calling about their child who has a liver disease. Does that matter? And there's very few studies about that. One was recently published. It was a retrospective look at all the literature. And as it turns out, kids with chronic liver disease have much less impact of their COVID. In other words, it does not appear that kids with chronic liver disease have any worse outcome than kids who are otherwise healthy. What we recommend at this time is that all kids should be managed with the guidelines of public health policies. Finally, kids with liver disease, if they are of age and eligible, they can receive the COVID vaccine. There's no contraindication for them to receive the vaccine.
Great. And as an addition, I've heard that some of the pharmaceutical companies that produce vaccines have actually started studying children ages 12 and up. So hopefully in the coming months, we'll get some more data on that as well.
Absolutely. Kids are now being tested in a study, ages 12 to 18, as you mentioned. And hopefully we'll have results soon, and so that we'd be able to lower the age of eligibility for this vaccine. I should also mention there was also an interesting study, Valerie, of mothers who are receiving vaccine who are breastfeeding. And as it turns out, the antibody that's generated through the vaccine actually passes through the breast milk and may be protective for their babies. So if you're breastfeeding and get your vaccine. Keep breastfeeding. It's probably healthy and provides protection for your baby.
Great. Well, thank you so much. It's been a pleasure. Thank you for answering all of the questions.
Well, thank you for having me, and it's been a delight time to be here. Thank you.